what we're going to do is we're going to go through a little review on COVID, and then we'll go through some of the newer information. So I think you saw some of this last year, but I just want to reiterate.
Someone's not on me. I got it.
You got it. So one of the things that we learned early on was the issue of, when we test, does the test always mean that they have active disease? And so most of the testing that we did and still continue to do does not necessarily tell you that they are actually infectious. It just tells you that they have viral particles present in great enough number to detect the test. So, these tests basically can't tell the difference between live and dead viruses. These are mainly the ones that we were looking at, I'm going to go on, which are the RT-PCR, the modified RT-PCR. So specimen types in order of viral load. The bronch, which we do very infrequently, I mean, that was one of the things we were looking at early on just because it had the highest diagnosis rate, but it was the greatest risk for healthcare workers. Sputum, NP swab, saliva, oropharyngeal swab, and then nasal swab. And a lot of it is just because we've moved over to a variety of different testing options. So, we know the ones that we have and we've been using for a year and a half, which is the RT-PCR, which looks for the specific RNA fragment. And the reason this is important is we still have to use this, and this is actually what helped us determine the new variant, which we'll talk about in a little bit. The modified PCR, which is our rapid, and that one is, one that hopefully eventually we will be using also in offices. And test is, typically you want to test within the first 7 days. These tests, though, tend to be positive for prolonged periods of time. So they're very poor for determining how long patients are actually quote unquote ability to pass viruses. We use that, nursing homes wanted them they had to be RT-PCR negative. So none of us do repetitive testing with any of these modalities. The antigen testing is what we see at home now. So there's tons of these antigen testing now. The Abbott Bionex is the one probably we see used the majority of the time. They're less sensitive, but they are very specific. And so if it is positive, then that patient or you are infectious at that point. So that is a difference. So that's a difference between the RT-PCR, and that's advantage of that for the home testing option. Antibody testing, we only use IgG. Originally, we were able to say that IgG would be positive in about 14 days, and we knew that the patient was infected. Now with vaccines out, IgG is positive from vaccines, so it's very difficult to determine, whether they have had a native infection if they've been vaccinated. So it's really not a useful test. We can't tell whether they're immune. It doesn't give us high or low titers, so it's much less advantageous to take. Some of us will check it if we want to know immunocompromised patients, if they still have antibodies at all, although it's not recommended for that. And the other is if you have a patient that comes in with Guillain-Barré syndrome and they've been not vaccinated, then it's worthwhile in determining whether they've been exposed and have antibodies for that. So there's very limited reasons to get IgG currently. Viral shedding, want to remind everybody, it is highest earlier on. So it's once they get symptoms, like you think of with any other virus, any other cold virus, because that's what we're really dealing with, people are infectious prior to the symptoms starting. Asymptomatic, pre-symptomatic transmission, it can be isolated even up to a week, especially with people who are vaccinated now. They may be transient carriage, so you may have a higher incidence of people, having virus in their nares and exposure, which is why I think the push for vaccination to try and decrease, even if you have exposure, that you don't get ill. I'm going to go on with this. So highest risk exposures, household contacts, still by far. So if somebody's gotten sick in the family, the odds are pretty high, especially unvaccinated, you're going to see the entire family come in. So that's the sad part. Healthcare settings, exposures, they are testing 2-3 times a week, at least weekly, staff. So it is a very aggressive program to try to decrease spread within our nursing homes, any group homes. So we sort of tackled that issue quite a bit. Environmental contamination. So viruses can live on the surface, so it's good still practicing basically hand hygiene, disinfectants. We don't really use anything UV light, sunlight, mouthwashes, anything that you can do to try and improve surface contact, obviously wearing masks, social distancing, we've all gone through that. Vitamin D and zinc supplementation. So, anything that we do, all of it has to be ahead of time. So we looked at, when we originally saw the alpha variant, one of the things we did was we tracked data at Mount Carmel with our antibiotic stewardship, and we found zinc was an independent variable. And that actually improved our morbidity, not necessarily mortality, but our morbidity. So I do think zinc supplementation, we still put that on patients when they come in the hospital also. But a lot of this is prior to. Clinical presentation, asymptomatic. So again, usually these are the pre-symptomatic people, as we were talking about. Symptoms usually cough, fever, myalgias, arthralgias, headache, shortness of breath, sore throat, diarrhea, and we saw a lot of GI symptoms with Delta. I would say we saw a little bit with Alpha, but clearly we had a marked increase with that. Okay, presentation, again, known exposure or high-risk activity. It typically starts, as you would expect, as a viral illness. The big ones are the dyspnea, and you'll get a little bit. So this virus, you get potentially just a URI, but you can also get a viral pneumonia. And so that's when you start seeing the changes on chest x-ray. Even if they're not symptomatic yet, you can still see some changes, bilateral ground glass appearance on chest x-ray. Then you can get more of an ARDS picture that happens about 7 days, sometimes 10 days. At that point, the viral load is starting to go down, and you really are getting more of this inflammatory response, and that's what really gives the majority of people problems. So if you can't capture that viral illness as far as some of these newer modalities early on and try and decrease that viral load, the progression to ARDS in the high-risk people is pretty significant, and that's what our hospitalizations are more related to that than to actual viral pneumonia. The other thing we saw with Delta was a huge increase in thromboembolic events. A lot of times they would have come in with PEs, significant PEs, DVTs. So if you have somebody who is out 7 to 10 days from their COVID positive test or their symptoms, and they're having significant shortness of breath, it's either going to be a thromboembolic event or it's going to be ARDS. And both of those will need to be established. All right, I think everybody sort of knows the differentiation, and these were based on some of the original stuff that we went through with remdesivir, our first antiviral medication, and what the definitions were that were put out by CDC, NIH. They all define differences as far as mild illness, moderate illness, and it was a lot of times based on this O2 sat of 94%. So we would give remdesivir if they hit 94%. So the main thing I think to know with that is that patients who start to be symptomatic and they start dropping their oxygen saturation, they are much more likely to go on to some progressive illness that they're going to need hospitalization for. If you can capture it with steroids early on, if they need, if they're getting that shortness of breath symptoms and you're starting to see a little bit of O2 sat decrease, if you can get those patients prior to progression, then you may be able to avoid hospitalization. But once they start getting into a lower O2 sat state, odds are they're going to end up in the hospital. All right, risk factors for severe COVID-19. So these are the big, and the focus is very specific. Those folks have a high probability of having morbidity or mortality from COVID. These are our breakthrough vaccination patients. These are our hospitalized morbidity and a high risk for mortality risk factors for patients who come in the hospital. So if you always keep your high-risk patients in mind and have and sort of treat them as a different subpopulation in this group, you need to be more aggressive with them. So if I have a patient who's coming in, like I have a 35-year-old male with sleep apnea, obesity, plus or minus diabetes, you know, and hypertensive usually if they have sleep apnea, you know, those folks get on high dose steroids. I mean, they're going to go, and this is what so we gauge everybody a little bit differently. So there's some cookbook recipes for what we do, putting on remdesivir, and we'll talk about this in a little bit, you know, 6 milligrams of steroids. If you have a very high risk patient and you start to see an oxygen change that's starting to change pretty quickly, we massively or aggressively go to higher programs of treatment options quicker. All right, vaccines. Vaccines have sort of changed our way of life. The mRNAs, I think everybody knows, Moderna and Pfizer. We have the attenuated adenovirus, which is the J&J, which was one vaccine, which probably was a mistake. They probably should have been a 2-vaccine treatment option. So natural versus immunity versus vaccinated immunity. So with natural immunity, so you've had COVID, you know, what are the odds of you having any type of immunity associated with that? So, you know, it's usually typically just to the one variant that you had, you know, you're going to form antibodies to the variant you got. So, you know, that's the difference between a vaccine and the natural immunity. So it lasts probably 6 to 9 months, may not have as much T cell. As far as the vaccine, you get many times more than one variant. You have probably immunity out to about 6 months. Now, if you have repetitive exposure to COVID, which is your sort of your trigger, you know, part of the reason why we see immunity go down is because we're all vaccinated and trying to social distance and trying not to get it. Unlike regular cold viruses that we see, you know, every month, especially if we have little kids. So part of the reason why these vaccines wane is because we are not exposed to it. We are not getting the virus again or getting something similar to that. So the vaccine for immunity-wise probably decreases about 6 months is what we think. The vaccines were effective through Delta. They have produced more B cell immunity, which leads to more antibodies. They also have T cell memory cells associated with it. Breakthrough infections, back to the high risk. So the high risk people are who we're seeing breakthrough infections with for vaccinated patients. So always, again, back to aggressively treat the high risk patients. And our hospitalized patients, 85 to 95% unvaccinated still, except for the breakthrough high risk. Oh. All right, sorry about that one. So as far as boosters, all 3 vaccines are recommended for boosters now for age 18 up. So everyone is eligible at 6 months for a booster. Also for children 5 to 11, they get about 1/3 of the dose and is recommended for Pfizer. Monoclonal antibodies infusions. So we had BAM and EDI that was effective for gamma and beta. It was restarted, or sorry, paused during gamma and beta. It was effective for alpha. It was restarted for delta. CAS and MD was effective for delta. That was the one we've been using most commonly. There is a new one that will be out that will be injectable also. So that may help, you know, decrease the issues for IV infusion clinics, you know, a quicker time frame to get the monoclonal antibody. So we're all hopeful that that will be, you know, an option here in the near future. You can use it with previously vaccinated patients. I think OSU and Riverside's making it within 7 days. Mount Carmel is still within 10 days. And no O2 requirement due to COVID. So if they are on oxygen for COPD, they can get it. If they're on oxygen for COVID, they cannot. High-risk groups are the ones who are eligible, and hospitalized patients, if they have an incidental positive and they're high risk, they can get it while they're in the hospital. If they're being treated for COVID and they have O2 requirement, they cannot. So it's only for patients who are not actively having symptoms interrelated to COVID that requires O2. Future vaccine should be 90 days from any monoclonal antibody infusion. All right, therapeutic options. Remdesivir, my personal opinion, we give it way too late. If you think of any antiviral, you're trying to get your viral load down. So we'll give it up to 10 to 14 days. but we've missed our window. So by the time they get into the hospital, these really should have been given, a lot sooner. And so I think that is debatable on what the effectiveness of remdesivir. I don't think we'll ever be able to figure out what the effectiveness of remdesivir is. Dexamethasone was our workhorse. And so, if they come in and they're having O2 requirements, they're on 2 to 3 liters, we put 6 milligrams on. It's typically for 10 days. Once they are no longer requiring O2, usually they don't go home with it unless they're having significant wheezing or they had a prolonged hospitalization. Many times we will go out with that. IL-6 receptor inhibitors, tocilizumab, or Actemra. So we do use this. We use it for specific circumstances. If they have a CRP that is greater than 7, and they are having significant O2 requirement elevation, or if they're a high-risk patient and we're starting to see a change in their oxygen requirements, we will put this on earlier. It does have some side effects associated. And the side effects associated with it is there is an increased risk for bacterial infection. It is a rheumatoid arthritis drug. It's under an EUA now. Prior to, what was it, the summer, we were giving it routinely. And when the FDA then came out with an EUA, so we have to discuss this with the patient and provide a fact sheet associated with it. We always did discuss it with the patient, but now the fact sheet goes along with that whole process. It can reactivate TB or other granulomatous diseases. So checking quantiferon gold, and we check also a PCT level, procalcitonin level, because if they have an active bacterial infection, we don't want to give it. If they also have an active malignancy, usually we will check with the hematology oncology physician to make sure that there's no contraindication for it. JAK inhibitors, we only had that option for potential use when they were limited, when there was limited supply for tocilizumab. Other hospitals around had used that. There is a huge increase in thromboembolic events with that. Not only did you have the issue of COVID creating that, but you had this drug creating that. So we tried to avoid that at all costs. Oral agents. So Merck has the first oral agent that is under FDA advisory panel review this week. It got sort of lukewarm results with that. I think it was 13 of 15 agreed to approve it, used within the first 5 days, mild to moderate COVID. Again, you have to have testing at home. You have to test at home, and if you're positive, you get the drug. If you're beyond 5 days, just the same way as with Tamiflu, then the odds are that you're not going to get the benefit from this agent. So this agent's kind of unique in that in the amino acids, if you have an amino acid strand, the drug actually inserts itself. And so, if you have C and G, this drug is now, M and G. And so it creates mutations, and it rapidly creates, with each replication, more and more mutations. So basically the virus mutates itself to death. So there was concern, so it's not indicated for pregnancy, because there is some concerns interrelated with the DNA structure. So that's where the lukewarm is. Is it going to create more mutations? Is it going to be, obviously, for pregnant patients? Is it going to change things? And so no one's really keen on this one. They're not quite sure what to do with this one. They know it's the first one. So, I don't know where this is going to shake out. I think everybody hyped this drug. It's $1 million for this agent. And it's sort of iffy based on what the FDA panel put in. The next one that's coming out is Pfizer, and the US has bought a lot of this. So it's a protease inhibitor. It's a novel protease inhibitor combined with ritonavir, which is another protease inhibitor that we use in HIV. So basically what it does is it binds, and then it doesn't allow the replication by the process of going from a long strand to a smaller fragment for the virus then to use the parts to replicate. So that will be the next one. I think that will be pretty soon. They're requesting an EUA currently for that. That one will have more traction, I think, than the Merck one, but we'll see. All right, anticoagulation. So we do check D-dimers when patients go in, looking again for thromboembolic disease. If that D-dimer is rising, then we check venous duplexes on all 4 extremities, and a lot of times a CT-PE protocol. We monitor the sick people. If their oxygen is rising or if they're in the ICU, that D-dimer is checked every day. And so we just look, for whether or not there's progression interrelated with that. When they go home, sometimes they need to go home on anticoagulation. If they have a known or history of VTE, a D-dimer greater than 3 anytime during the hospitalization, or a CRP greater than 10, a lot of times that's what you're going to end up having to do is 30 days at least of some type of anticoagulation when they go out. Need for antibiotics, everybody got antibiotics to begin with. But because it's a viral pneumonia, unless they had a PCT level, procalcitonin level that was elevated, usually above 0.5, typically they don't get antibiotics now. So they have to have some other thing, abnormal urine, if they're coughing up anything, but if they're coming in with a straightforward COVID, we don't typically do this. All right, discontinuing isolation. So the main reason I wanted to put that, I think everybody knows the ODH and CDC guidelines for discontinuing isolation at home. For hospitalized patients, we do the same. If their oxygenation is improving, it's 10 days after symptoms start. But if they're immunocompromised or if they're on in the ICU or on IRBO, typically we at least do 20 days. And it's physician discretion if they want to go longer if they're on IRBO or BiPAP. All right, the new topic that everybody is so excited about, just what we needed, another variant just for the holidays. So what's the difference with this one? Heavily mutated in that spike protein. So it was confirmed, the first one on 11/9, reported to World Health Organization 11/24. So one of the things, the PCR test, that's how they picked it up. If they had to do, so they do in South Africa more whole gene sequencing. So, they do more than what we do, but what they found was on the PCR testing, there was a S gene of the 3, so one of the target genes, an S gene dropout. So it missed one. So they said, hey, why are, this is different than everything else we've seen. And so there's something wrong. And so that's how the variant came out so quickly. Otherwise, it wouldn't have been out determined as quickly as it was. So there was a sharp rise in South Africa over the last 2 weeks. About 90% of infections were now the Omicron, gotta get it right. It was detected in everywhere, so they say Hong Kong, Israel, Belgium, UK, it's gonna be everywhere. So California today, but this is out of the bag. This thing's highly infectious and it's moving. Hits greater than 50 mutations compared to the original, greater than 30% in the spike protein, and what the importance of that, it makes it more infectious. So that spike protein mutation increase we saw in Delta, and so we had a much higher infectivity rate with Delta. It has some of the same mutations as Delta and Alpha, therefore the question is, are the vaccines going to be effective? And we'll know that hopefully within the next 2 weeks. Pfizer was very optimistic with, we'll know this within 2 weeks, we'll have 6 weeks to adjust it and 100 days to ship it out, and Moderna's like, whoa, what are you thinking? And so, we'll see whether that actually materializes. But the bottom line is, please do not tell patients to wait for this vaccine. Delta is our problem. So we'll see whether this one will replace it, but Delta is our problem, and that is what we are seeing. And we're seeing a huge uptick in the amount of COVID infections we're seeing in the hospitalized patients currently. So, we don't know what the morbidity and mortality rates of Omicron is yet. What we do know is, at least in South Africa, where the vaccinated patients were getting it, it was milder. They were tired, sore muscles, light cough, but they didn't have any loss of taste or smell. So it sort of was some of the parameters that you use for your regular other differentiations between other cold viruses, flu, you're not seeing that with this one. Questions?
2 questions for you. One, can you reiterate the recommendation for zinc, vitamin D, and doxycycline? Is that at symptom onset, and what dose?
So vitamin D, there's people who do anywhere between 1,000 to 5,000 international units. And again, I prefer vitamin D. We saw no benefit with vitamin D after onset. We still do it, but it's really prior. Zinc to 220, I think it is, that we give, zinc sulfate. And again, beforehand, but we do that in hospital too. Doxycycline's iffy, it's just an anti-inflammatory activity is all we're looking at. I think more people have not had benefit with doxy. So I would say in general, that's, 50-50 on whether we put that on. If they're having a little, we defer out to that one if they're having any, productive cough at all.
Okay. Second question was for outpatient treatment of COVID-19, would you mind please repeating the role of steroids?
So the main reason for steroids would be if somebody is starting to have, so two reasons. One is if they're an asthmatic and they're starting to have, something related to their underlying asthmatic component. The second is when you're starting to see any type of oxygen decrease. So, you get a pulse ox. So high-risk people, if they start to have an oxygen decrease, getting them on steroids may help decrease their admission. And steroids normally, so when we look at steroids in the hospital, it's Decadron. And the reason it's Decadron is because it has less ability to have leakage as far as the leaky lung. It was our ARDS studies that showed that. So that's why Decadron is used over anything else. So as far as oxygen levels go, you have to know what your norm is. And then if you start seeing that, especially if they're going down 92, 93%, they probably need to be on steroids with the hope that that would decrease your odds.
I think that's all we have for questions. I think the one other comment that I would make is, fortunately, COPC did get into the monoclonal antibody business at about the right time, because what we hear from ODH is that the oral medications will only be available through sites that administered monoclonal antibodies. They won't be available through retail pharmacies. They want to process very much like they had for monoclonals, that people have a positive test and are exhibiting symptoms and are high risk, and that's to avoid the Tamiflu event where people go get a script of Tamiflu and put it in the cupboard just in case for later. So hopefully once that becomes available, we'll have that option to distribute it as well. So.
Great.
Are you going to do the next one?
Yeah, I'll do the next one.
You said hit escape on the keyboard. And then I think you can just minimize it up in the upper right corner.
Am I on it?
Further right. A couple more. One more. There you go. And then PowerPoint in the, yep. And there's up in the top bar, all the way up, nope, top bar, a little higher up, all the way to the right. That, just one to the left, that icon, one to the left, that icon. There we go.
Good. Thank you. All right. So I thought the other thing we talk about is we do a fair amount of wound, and I think that we've done this sort of every year. So I just wanted to go through diabetic foot ulcer, because I think this is kind of a big deal. We see a large percentage of diabetic foot ulcers. So one of the things that makes a difference is when you're examining a patient, if they are starting to see changes, and especially the changes of pressure, it is something that is going to need to be dealt with, again, pretty aggressively, because they are starting to get structural changes. So structural changes is that they're starting to get, a lot of times, this Charcot situation where they're getting progressive. They get these micro fractures in the metatarsal head area, and then they can lead to something that is more like that rocker bottom club foot type change. And it's much more difficult to get rid of an ulcer as they move to a Charcot foot. Those are usually something that's going to need casting and something that's going to need, again, a podiatrist that's fairly aggressive. So why the importance of diabetic foot ulcers? So if you look at lifetime risk for patient with type 1 or type 2 diabetes, about 34% of patients will get diabetic foot ulcers. It accounts for a marked increase of hospitalizations, for treatment of infections, treatment of wound management, and high rate for readmission, just because, they go out and walk on their foot again and they get, repeated pressure changes, and amputations can be up to 20% of diabetic foot ulcers. So it's a big deal once they get amputated, because then it changes. So if you have somebody who has, if you have somebody who has this and you amputate that, then this one is next, and then so forth. So it's kind of a giant deal. If we can try to keep the original structure of the foot, that still is the highest odds of what we want to do. So there is about a 2.5-fold increased risk of death related to diabetic foot ulcers, and part of the reason is why they form them, and then associated infections with those, and then amputations related to that, IV antibiotics or other antibiotics that create, renal problems and, the chronic inflammatory process. So main risk factors for the DFU, diabetic foot ulcer: previous foot ulceration, neuropathy, which is present in about 80% of patients with diabetic foot ulcers, foot deformity, hammer toe, Charcot, vascular disease, large vessel, and it can be also microcirculation, as most of them will get microcirculation through time. Other risk factors are what you check: hemoglobin A1C, leg edema, foot swells during the day, and then they're in a shoe, and then they rub. Nutrition, making sure they have albumin and prealbumin, and identifying if they have any proteinuria that would lead to potential for hypoalbuminemia, and then smoking, which causes vasoconstriction. So when you look at getting some type of diabetic shoe, a lot of this is what's on there. That's on the form. Have they had anything? If they've had any previous foot ulceration, if they've had any amputation, if they have neuropathy or foot deformity, these patients can get some type of diabetic shoe covered by Medicare, if they're on Medicare. What it means with that is that they can get a wider shoe, and they can get a larger toe box, which decreases the odds of them getting the pressure changes over time. So any person can order these diabetic shoes. It always tags to the primary care doctor to also sign off that you are treating the diabetes component of it. But this is a giant deal, and patients won't change over early. And like the foot stores, like Good Feet store and that, they don't have shoes that have large enough toe boxes. Patients don't like to go to the orthotic places to get them because they're heavier, but it is crucial if they start having these changes in their feet to try to get them to motivate to get something different. So assessment of loss of protective sensation: they just don't feel, they don't know. They see blood on their sock and it's too late. They already have the ulcer at that point because they've had the callus, they can't feel it. They've had a new pair of shoes, they rub a friction blister. So knowing whether or not the patient has neuropathy is a big deal. You can check it with a monofilament test, checking pulses, absence of pulse, or if they have prolonged diabetes, getting that ABI and correcting any vascular component to this. Autonomic dysfunction: a lot of them will have venous insufficiency. They will have autonomic dysfunction that causes more swelling, more changes in ability to sense things, and there's a high correlation of coronary disease. So if you have any other peripheral vascular disease, knowing that helps you determine whether or not you need to assess for coronary disease too. In the skin, if they have athlete's foot or calluses, that puts higher risk for infection, which can lead to blistering and lead to increased risk of open wounds for the diabetic patient. Bony deformities, joint mobility issues: they change their gait because they have a bad knee now, their balance is off. All those things lead to pressure changes, which lead to progression for foot ulcerations. So these are the target sites for sensation. if you're going to check that. This is what we check at the wound center. So they check on the feet and they check up to about the knee. Assessing the diabetic foot ulcer, you want to know what the cause is. And so is the cause related to something that's a structural deformity that needs corrected? You know, hammer toes need corrected, they need casted for their shark of foot. Or is it related more to something that, you know, swelling wise, you know, they're sleeping with their feet down. I mean, all these things need to be asked on, you know, what the actual cause is. New shoe, depth, if it proves to bone, the odds are it's osteo. So it's osteo until proven otherwise. Infection, you know, getting a culture, ischemia, checking for, you know, your vascular disease, and then controlling hyperglycemia. If they're hyperglycemic, the odds are they're infected. So if you're having, you know, something that is controlled and then all of a sudden it's not, then odds are there's some type of deeper infection, either from the wound bed and progression of sort of like necrotic tissue or a bone infection. So we look at classifications. The classifications are based on a Wagner grade. So the superficial ulcer is one that sort of barely breaks the skin. Then you get into the deep ulcer, which is a stage 2, which goes into an infected deep ulcer, which is what we call grade 3. And then the other ones are more related to ischemic. And the reason this is important is when we look at this in the wound center, we're looking at things that are adjunctive treatment sometimes as far as management goes, and the grading systems helps us determine how we go about imaging, how we go about alternatives for therapy. So when we have a patient come into the wound center, we screen for ABIs. We sort of debride anything that's abnormal tissue because we want to know what the depth of infection is. We do a tissue culture. We treat the infection based on what we are seeing, either topical, oral, or intravenous. Dressing management, there's a whole slew of different ones, and some have silver that helps as an antimicrobial. Others are wicking dressings, so we determine whether they're having a lot of drainage, if they have a venous component with it, or if they're drier, which means for us more likely there's an arterial component. Offloading options. Initially, we put them in a post-op shoe. A lot of times we will add in some foam to try and offload pressure, and then ultimately trying to get them into some type of footwear that more permanently offloads. There's what's called a Pegasus. They can buy these on Amazon. It is an offloading foam. They can pull out the little peg. They're really cheap. So we can put those in like a post-op shoe. You know, sometimes we'll put them in other shoes. Some people will put them in bedroom slippers. You got to get them off the foot right away. That, if I can't say that enough, that is the one thing that there are some just jury-rigging options that you can do immediately, because the more they're stepping on that, the higher the odds that they're going to end up with more progression of a need for amputation short of time. So when we look at the wound clinic, we look at it for a couple different reasons. We look at it for, you know, some basic management, and because we do infectious disease, we look at some, you know, management for, you know, antibiotics and for if they need IV antibiotics and imaging. But we also look at it for grafting, you know, after they've had 30 days of wound center or wound management. That's an option. There are multiple different ones, especially for diabetic foot ulcers. We look at the adjunct of HBO. If they've had 30 days of standard wound care and they're grade 3 or greater, that is a potential option. I would say we do that in less than 2% of patients. You know, they really need to justify that they need that course of therapy. Infection being treated, we go through education with diabetic control, you know, the primary care, being actively involved with diabetic management, nutrition, the smoking. But the goal is, and 100% what we try to do is you got to get it healed, and you got to get it healed fast. The longer that wound is open, the higher the odds you're going to have infection, the higher the odds for amputation. Okay.
I'm not sure everybody knows that you all staff the wound clinic.
Okay.
Would you just give a little plug for yourself?
Okay. So what do we do? So the majority of our wounds that we need to manage, a lot of times we will handle out of the wound center. because we can do, debridements, we can do, sort of more, I guess, more aggressive, you want to put it that way. Some of the stuff we can handle in the office, and we do some stuff in the office, but, compression wraps, judgment calls on how we need to do that. Some interdisciplinary, referring to podiatry or other things. So what we do, there's 3 of us in our practice that go to the wound care center, Dr. Ha, Dr. Bobulin, myself, and we're at St. Anne's and Mount Carmel East Wound Center. The advantage of that is we try to get people in pretty quickly. And like I said, the whole goal of this is to try to get them in, define what they need, and try to get it healed and try to get it not to come back. And to educate patients on what to look for to have it not come back. And I think that, I did this originally so that I could see the inpatients and bring them over. It's been advantageous to also have COPC and allow options for patients to come quickly to try to get other advanced modalities. Because it's kind of a pain to order all these supplies to try and manage that, and we see them often. So it gives us a better opportunity to see patients often so that we know that they are compliant with their therapy and moving it along in a more rapid format.
Great, thanks.
Okay. Any other questions on that?
I don't have any other questions in the chat or the email, so.
Okay, thank you.
All right, let me know when I should start.
Go right ahead.
Okay. So I'm going to be talking about antibiotic stewardship today. COPC is planning to start an antibiotic stewardship program. It was supposed to start this year, but because of the pandemic, it's been delayed, and who knows when it'll really take off. But I'm going to kind of give the introduction to what antibiotic stewardship is.
Johnny, can I interrupt for 1 second? And Jane, there's a microphone right above you. I did get one more question in, so you don't have to go back up. Should all of us be taking zinc? Will that protect us from getting COVID? And 2, for the monofilament test, what else can we use if we do not readily have a monofilament available?
All right, so as far as the zinc goes, I think everybody should be taking zinc personally, if you're asking me. I think that and vitamin D, and that's more for prophylactic type thing, will prevent you from getting sick. I don't think it will prevent you. It's more for whether it will decrease your symptoms. As far as the monofilament, anything that you can do to test sensation. There's, because all you're wanting to do is, the advantage of the monofilament is tiny. And so, therefore, you're trying to get little tiny recognition, but you can use anything that would elicit. So even like, I hate saying a little needle, but you could use a little needle, anything that would be able to discern sensation. Better than a fingertip, though. I don't think that's an accurate measure.
Thanks. Sorry to interrupt.
Oh, no problem. So this is directly from the CDC website. And I'm only going to give a couple slides from there. I don't want to be exhaustive in covering this topic. So basically, antibiotic stewardship is the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. Improving antibiotic prescribing involves implementing effective strategies to modify prescribing practices to align them with evidence-based recommendations for diagnosis and management. And there's 4 core elements, and this is for outpatient antibiotic stewardship. Number 1 is commitment. Number 2, action for policy and practice. Number 3, tracking and reporting. And number 4, education and expertise. So commitment is to demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety. Action for policy and practice would be implementing at least one policy or practice to improve antibiotic prescribing, assess whether it is working, and then modify as needed. Number 3, tracking and reporting would be monitoring antibiotic prescribing practices and offer regular feedback to clinicians, or have clinicians assess their own antibiotic prescribing practices themselves. And number 4, education and expertise. Provide educational resources to clinicians and patients on antibiotic prescribing and ensure access to needed expertise on optimizing antibiotic prescribing. So we'll kind of focus on the last part, the education and expertise. Oh, darn. Sorry, I pushed the wrong button. I think I do it on this, right? Okay. So antibiotic stewardship is the effort to, 1, measure antibiotic prescribing, 2, improve antibiotic prescribing by clinicians and use by patients so that antibiotics are only prescribed and used when needed, 3, minimize misdiagnoses or delayed diagnoses leading to underuse of antibiotics, and 4, ensure that the right drug, the right dose, and the right duration are selected when an antibiotic is needed. So I'm going to cover a few common infections that we see all the time. So pharyngitis, upper respiratory infections, lower respiratory infections, and urinary tract infection. We'll review some of the algorithms of care, some of the flow charts, and review some helpful tools for more complicated cases. Because of the time restraint, we'll kind of go through kind of important points, but not everything. And most of this you can find on UpToDate. They have these kind of flow charts, and it's kind of helpful in terms of where to go from one situation to the next. So basically, we're trying to discern whether you're dealing with a virus or a bacteria, or maybe something that's non-infectious. Because if it's not a bacteria, we don't want to use antibiotics. That will decrease antibiotic resistance and also decrease side effects from antibiotics. So when we're dealing with acute pharyngitis, things have changed since COVID-19. So any upper respiratory symptom, whether it's sore throat, sinus drainage, sinus congestion, sneezing, cough, myalgia, loss of smell or taste especially, COVID-19 is in the diagnosis. So you want to start off by ruling out COVID-19. But there are a few things that, is there a pointer? I don't think there's a pointer.
What folks used last week.
Oh, here we go.
Yeah.
Okay. So there are a few things in acute pharyngitis which may help differentiate a bacterial infection from a viral infection. So the absence of cough would point more toward a bacterial cause. Tender and swollen anterior cervical nodes, lymph nodes, would point more to a bacterial cause. A temperature greater than equal to 100.4 or 38 degrees Celsius also would point more toward a bacterial cause. And tonsillar exudates or swelling will also point more towards a bacterial cause. If you have all 4 of those criteria plus the sore throat, then it's probably going to be a bacteria, and especially group A strep. So you may want to go ahead and treat it as group A strep infection. If it doesn't fulfill all the criteria, then we may want to test a rapid strep. If that's negative and you feel that it is a bacterial infection, you may want to do a throat culture at that point. If they have none of these criteria, then it's probably a virus, probably don't need to test, probably don't need to treat with antibiotics. If you do decide to do a throat culture, you can wait a couple days and just follow up on the patient. You don't have to start an antibiotic right away, unless there are some other alarming symptoms or findings. So this is going to be hard to read. I'm glad this slide is very big, but basically, I'm just going to go through this quickly. There are certain situations, if someone presents with pharyngitis, if they have a muffled voice, if they're drooling, if they have stridor, if they have respiratory distress, if they have the tripod position, that basically means they're leaning forward and putting their hands on their knees, and they're stabilizing themselves so they can use their accessory muscles to breathe better. If they have trismus, if they have bulging on one side, which would be concerning for a peritonsillar abscess or even a retropharyngeal abscess. If there's any of those issues, then we're going to have to, go a different route. You may need to do a CAT scan. You may have to send them to a specialist, etc. If it's just a regular sore throat, a regular pharyngitis, then I would go ahead with testing for COVID-19 and a rapid strep. If you think it's bacterial, you can, and the rapid strep is negative, you can do a throat culture. You don't have to treat with antibiotics right away. You can just follow up with them in a couple days. You will not increase the risk for rheumatic fever by waiting a couple days. There could be a possible chance that if they have a peritonsillar abscess that could worsen during that time, but we want to have close follow-up. This is one way we can reduce inappropriate antibiotic or using antibiotics when it's really a viral infection and not a bacterial. So let's say the rapid strep is positive, the throat culture is positive, or they have all the kind of classic symptoms for group A strep infection. How do we treat this? If they are not allergic to penicillin, then the drug of choice is penicillin or amoxicillin for 10 days. If they have an allergy to penicillin, it kind of depends on what that allergy is. So if it's a rash, if it's not a severe allergic reaction, then you can use cephalosporins. If it's anaphylaxis or some kind of respiratory issue, then you probably don't want to use a cephalosporin. So instead, you should go with clindamycin or maybe even Zithromax. Something about clindamycin in regards to using a right dose and duration. I've never really used clindamycin at a higher dose than 300 milligrams 3 times a day, unless it's toxoplasmosis or something like that. Clindamycin is difficult to tolerate, so 300 milligrams 3 times a day is plenty for skin and soft tissue infections, abscesses, pharyngitis, etc. So just to review, group A strep, pharyngitis. It's the most common cause of bacterial pharyngitis. All patients who are symptomatic and test positive should be treated. If they're asymptomatic, then they don't need antibiotics. Treatment reduces symptoms and speeds up recovery, prevents complications such as otitis media, peritonsillar abscess, even meningitis, etc. Treatment prevents acute rheumatic fever. It reduces transmission to close contacts, and it probably prevents post-streptococcal glomerulonephritis. Do not treat chronic asymptomatic carriers. Penicillin or amoxicillin is the treatment of choice if they are not allergic to penicillin, and the duration of treatment is 10 days. Penicillin allergic patients can be treated with cephalosporins if it's a mild allergy. So cephalexin, which is Keflex, 500 milligrams twice a day for 10 days is appropriate, or clindamycin, 300 milligrams PO 3 times a day for 10 days, or even a Z-Pak. So when we're seeing these patients, there is, I don't know if everyone's familiar with the respiratory viral PCR panel. We use it a lot in the hospital, and it's probably best reserved for a patient with pneumonia when it's difficult to differentiate whether they might have a viral pneumonia or a bacterial pneumonia. If it's just a regular cold, upper respiratory bronchitis, the cost is probably not warranted in terms of using this. But I just wanted to show you what is on the panel. So it will test for adenovirus, for pertussis, chlamydia pneumoniae, various coronaviruses, including COVID-19, influenza A and B, metapneumovirus, RSV, rhinovirus, and enterovirus, and then the parainfluenzas.
So I've never heard of metapneumovirus.
So this is kind of a grouping of upper respiratory tract infections such as sinusitis, cold, nonspecific upper respiratory infections, and uncomplicated bronchitis. So uncomplicated bronchitis would be someone that does not have COPD or bronchiectasis. these infections are almost always viral. So if you see a patient in the office and they have sinusitis, uncomplicated bronchitis, cold, or some kind of upper respiratory symptom, so what would those be? Well, you could see cough, rhinorrhea, sinus congestion, sneezing, pharyngitis or throat pain, headache, myalgias, and then of course loss of smell or taste is pretty classic for COVID-19. So you'd want to rule out COVID-19. And in regards to sinusitis, if they have a high fever, and this would be like 102 or higher, if the symptoms have been going on for more than 4 days, if they have purulent nasal discharge and facial pain, then those are signs that this could be a bacterial sinusitis. So you would want to consider treating with antibiotics. Uncomplicated bronchitis is almost always viral, unless you have pertussis or maybe one of the atypical organisms like Mycoplasma or Chlamydia pneumoniae. So acute rhinosinusitis in adults. Most commonly due to a viral infection. You want to treat them symptomatically, and it resolves in 7 to 10 days. If the sinus symptoms do not improve after 10 days, then you have to consider that they have a superinfection with a bacteria or something else is going on. Only 0.5 to 2% of these infections are due to a bacteria. It may be self-limited, and most resolve even without antibiotics. So patients who are immunocompetent, patients who can follow up within a week, and they can be observed without antibiotics, because rarely does this progress to a severe disease or complication, such as orbital cellulitis or some other head and neck serious infection. Viral sinusitis usually resolves within 7 to 10 days. If sinusitis is not improving after 10 days, then reassess for bacterial infection. Treat bacterial rhinosinusitis for 5 to 7 days. So it's going to be shorter than pharyngitis due to group A strep. And the drug of choice would be amoxicillin if there's low rates of pneumococcus resistance, or Augmentin. If they're penicillin allergic, then you could go with doxycycline or a 3rd generation cephalosporin. So here's another flow chart that's hard to read, but basically this is for treatment. So it's kind of what we talked about. If there's low rates of pneumococcus resistance, you can do amoxicillin, otherwise Augmentin. You want to treat for 5 to 7 days. If they're allergic to penicillin, you can do doxycycline, you can do a 3rd generation cephalosporin. And then we kind of talked about some of the things that you would look for if it's more of a bacterial sinusitis. Now, these are for, uncomplicated cases. If you have a very complex patient who's had recurrent sinusitis, they're uncontrolled diabetic, and you have to consider other things going on. They may need to get sinus cultures, they may need to see ENT, and they may need to be treated more specifically with different antibiotics if it is bacterial. So acute bronchitis is characterized by acute onset with persistent cough, with or without sputum production, without evidence of pneumonia, in the absence of COPD. It typically lasts 5 days to 3 weeks. It's most often due to a viral infection. So, COVID-19, influenza A and B, parainfluenza, other types of coronavirus, rhinovirus, RSV, human metapneumovirus, etc. Bacterial causes are very uncommon. In one study, only 6% of acute bronchitis cases was due to a bacteria, and most of those cases were Bordetella pertussis, Mycoplasma, or Chlamydia pneumoniae. Antibiotics are not recommended unless it's due to pertussis. And if the symptoms, the cough, has been going on for more than 3 weeks, then antibiotics are not going to do anything. So this is another flow chart for evaluation of acute bronchitis. We kind of covered most of it on the other slide, but the thing I wanted to cover was we have to differentiate acute bronchitis from pneumonia. So if the patient has a fever greater than 100.4, if they're tachycardic, if they have an increased respiratory rate, if they're hypoxic with an O2 sat less than 95%, if there's signs of consolidation on the exam, or if they have mental status changes and they're over 75 years old, then those are hints that this could be a pneumonia. You can check a chest x-ray, and then you can go from there. Let me go to the next slide here. So it is pneumonia. It could be viral, it could be bacterial, it could be something else. So most commonly it's due to pneumococcus, Streptococcus pneumoniae, or a respiratory virus. So COVID-19 would be also something we need to rule out, especially during this pandemic. Less likely causes would be Haemophilus influenza, Moraxella, Staph aureus, Group A strep, and the atypical bacteria like Legionella, Mycoplasma, Chlamydia pneumoniae. All the respiratory viruses that we've talked about can cause viral pneumonia. These are all the viruses we also saw in the upper respiratory PCR viral panel. And we do use that in the hospital because sometimes it's difficult to tell whether someone has a viral pneumonia or a bacterial pneumonia. Unlike the sinus secretions, the sputum, viral and pneumonia can cause discolored sputum, yellow, green, even blood in the sputum. So that doesn't really conclusively differentiate the two. Of course, you can send the sputum for culture, and that'll help if you have a predominant organism that grows. There's also urinary antigens for Streptococcus and Legionella. I typically check blood cultures even if they don't have fever, because I've found that even though the patient doesn't have a fever, sometimes the blood cultures come back positive, and that'll give you the diagnosis. A lot of these pneumonia cases don't have a firm diagnosis. Even after doing the upper respiratory PCR panel, blood cultures, urinary antigens, sputum culture, HIV testing, all those can be negative, and you just don't isolate a specific bacteria. So how do we manage this? So if we think this is a bacterial pneumonia, we would want to cover for Streptococcus pneumoniae and also atypical bacteria. And especially for pneumonia, procalcitonin is very helpful in distinguishing bacterial versus viral infection. So let me skip this for a second and come back. So procalcitonin is something we also use for COVID-19. We've used it in every patient with COVID-19. Why? Procalcitonin levels are due to procalcitonin synthesis in tissue that's released into blood. So if it's a limited infection like a urinary tract infection or a skin and soft tissue infection, a procalcitonin will usually be negative, so it's not helpful. It's very helpful for pneumonia. So in a bacterial infection, endotoxin and certain cytokines promote the procalcitonin synthesis. Viral infections and viral pneumonia do not. Non-infectious, there are some non-infectious causes of an increased procalcitonin. And some of those would be any type of shock, trauma, surgery, burn injury, and even chronic kidney disease. So sometimes in the ICU, the procalcitonin may not be as helpful. Procalcitonin levels below 0.25 is almost never due to a bacteria. Procalcitonin levels between 0.25 and 0.5, they say is equivocal, but from my experience, if it's under 0.5, it's most likely not a bacterial pneumonia. Now they could have a UTI, like we talked about. They could have a abscess, soft tissue abscess. That will still be a negative procalcitonin, so that's not helpful for that. Procalcitonin levels above 0.5 could be bacterial, could be from some other causes of increased procalcitonin. So like a systemic candidal infection, candidiasis, Candida in the blood will also cause an increase in procalcitonin. Other fungi can cause some elevation in the procalcitonin. So you have to kind of keep everything in mind. But just to make it simple, procalcitonin, the patient has pneumonia. It's helpful to differentiate a viral versus a bacterial pneumonia. And that's how, when we have a COVID-19 patient in the hospital and their procalcitonin is less than 0.5, we'll stop all antibiotics unless there's evidence of an infection in the urine or somewhere else. Also, when you're treating bacterial pneumonia, decreasing procalcitonin levels are helpful in determining when you can stop the antibiotic. You can stop the antibiotic after 5 to 7 days if the procalcitonin level is elevated and then goes to normal. Okay, so I'm going to try and go backwards. Let's see. Okay. So for treating, I think I have a slide for communicable pneumonia actually here. No, I don't. Never mind. So when you're treating bacterial pneumonia, you want to cover for Streptococcus pneumoniae and also for atypical bacteria. So to cover Streptococcus pneumonia, it all depends on what's the level of pneumococcus resistance. So can we use amoxicillin? Should we use augmentin? Should we use a third-generation cephalosporin? For the atypical bacteria, you could use doxycycline. You could use one of the macrolides, which would be zithromax, Biaxin, erythromycin. And if they have some type of structural lung disease like advanced COPD, they would be at increased risk for Pseudomonas. So anyone with bronchiectasis is also increased risk of Pseudomonas. You may want to use Levaquin or Cipro or something like that. If there's anything else to add there, okay. So I know we're going through this really quickly, but we had a lot of things to cover. So you can go back and look at the slides and look at the flow charts and what have you. So the last thing I wanted to cover is urinary tract infections. So from training residents and medical students, I've learned that a lot of people have a misunderstanding of how to read a urine culture and a urinalysis and what have you. So let me just say, if you have a positive urine culture, it doesn't really matter if you have 500 colonies of E. coli or greater than 100,000. If you have a symptom of a urinary tract infection, a positive culture is a positive culture, whether it's 500 E. coli or greater than 100,000 E. coli. So we're going to treat that E. coli. If the patient has no symptoms of a urinary tract infection and you have greater than 100,000 E. coli, that is just asymptomatic bacteriuria. It's urine that's colonized. It doesn't matter that there's a greater than 100,000 E. coli. It has no bearing. Sometimes from the students I've taught, they think that if it's greater than 100,000, then it's an infection, we need to treat it, what have you. You don't have to treat the urine unless there are symptoms. So that would be dysuria, frequency, urgency, suprapubic discomfort or pain, flank pain, fevers, chills, mental status changes, etc. So there are a few situations where the patient will have no symptoms and the urine is positive for bacteria in which you would treat that. It would be women who are pregnant, if the patient is going to have a urologic procedure, and especially an invasive urologic procedure, because they will become septic and bacteremic if you don't treat the urine at that point. And then patients who are neutropenic. Those three situations, you would treat what grows out of the urine culture. And every other situation, if the urine culture is positive and the patient has no symptoms, you don't have to treat it. So no antibiotics. If it's an acute uncomplicated cystitis, which would be in a woman, you would treat with, there's a list of antibiotics there. So 5 days of macrobid, or 5 days of a cephalosporin, or 3 days of Bactrim, or 3 days of Cipro or Levaquin. So it would be 3 to 5 days, depending on which antibiotic you treat with. You could treat them empirically, or if you get a urine culture, you'd want to go by the sensitivities and the type of organism that grows. Complicated cystitis, you would treat for 7 to 14 days. And those would be men who have a urine infection, someone who's pregnant, someone with diabetes, someone who's had symptoms for greater than or equal to 7 days before seeking care, someone with urinary tract obstruction, someone with indwelling Foley or stent or nephrostomy tube or a urinary diversion or ileoconduit or urostomy, also called, someone with a renal transplant, or someone who's immunosuppressed. You would treat longer than 3 to 5 days. You would go to 7 to 14 days. If someone has acute pyelonephritis, you would want to do about 7 to 14 days. I go more towards 14 days. So some of the choices would be a cephalosporin, Cipro, Levaquin, Bactrim, but it kind of depends on what the urine culture says. And sometimes the urine culture doesn't list all the antibiotics, so you may have to call the microlab. Sometimes I've been called for IV antibiotics, and I review the sensitivities, and Rocephin is sensitive. Well, if Rocephin is sensitive, you can use a 3rd generation cephalosporin by mouth. There's also an antibiotic called phosphomycin, which is a one-time 3-gram dose, which activity against ESBL positive E. coli. So I've used that in some patients who are not that sick. That could prevent them from having a PICC line and IV antibiotics like Invance or meropenem or something like that. So I know that was very quick, but it's going to be on the slides. You can look up the flow sheets. You can call us or Doc Halo us if you have any questions on a specific patient. And then
thanks. A comment and 2 questions. So the comment is this, you know, we don't choose the topics for these lectures just randomly. Antibiotic stewardship and appropriate use of antibiotics is something that almost all of our commercial insurance plans are beginning to look at. So it's going to be an area of focus within the company, and we thought it was a good time to introduce the subject, and over the next year, we'll be providing more information and talking about how we're going to look at this and how docs can access the data and look at their prescribing. One of the questions was, so with your comment about not needing to treat asymptomatic bladder infections, patients treated in the outpatient setting who are symptomatic and have a positive culture get treated and become asymptomatic. Do they need a follow-up culture?
I never check a follow-up culture unless they're going to go on to get a urologic procedure.
Got it. And the other question was, one of our physicians is an avid fisherman and said they're thinking about just grabbing some of the monofilament line out of their tackle box. Do you know the gauge of the filaments?
I don't, but I say the smaller the better.
The smaller the better. Got it. All right. Thanks, everybody. I don't see any other questions, either email or in the chat. So appreciate everybody's time tonight, and thanks to the infectious disease group for the lectures.
Thank you.